my presentation, which is the current practices of fertility preservation. And imagine in 1991, we found this poor mummy, the Otzi, the Iceman, which was frozen probably so many years before Christ even, many years ago, and we could not bring this man to life. However, over the years, over this last century, there have been so many strides in scientific advancement that today we are able to freeze life and refreeze it and bring it where it is. So semen cryopreservation was first introduced, and that is what has led to actually where we are today. And I'm very proud to announce one of our latest additions. This is a breast cancer patient where FET was done 8.5 years ago, and we did a frozen embryo transfer. This child has been born very recently in July 2020 after a span of 8.5 years. So there is a lot of hope in this discipline. So let's go on further. So the aim of my presentation would be therefore to address these key questions. Who needs this? What are the fertility preservation options that we have today? What are the pregnancy rates with these options? Is there any risk of cancer again because of this? And what is the future of this developing discipline? What does it hold for us? So let me just take you through all these questions. This, as we know, is the graph of declining ovarian reserve, and we are very worried about it within normal women as well as patients of cancer. We are worried as to why the ovarian reserve is falling and whether we can do anything about it. And our hope and endeavor is to actually take it back to where it was and make our women as young as possible with as many eggs as possible so that they are all fertile. That is our endeavor. And this fertility preservation is our option and our is the game changer for us. So we have two types of patients these days: patients with pathology, which could be non-cancer and cancer, and patients with no pathology. These non-cancer patients could be either postponing pregnancy because they are not yet ready for it, or they may even be postponing their menopause, which is a very recent addition to the block. And therefore, the endeavor is to keep the woman young as she was in her adolescence or as young as she was during her reproductive age, and never to let her go into menopause. So with that, we are advancing, trying to make all these women of various kinds as fertile and as young as possible. Not just fertile, but as young as possible. So what are the factors which we need to consider when we are doing fertility preservation? Whether it is a cancer or a non-cancer patient, the age is very important. If the patient is already past that age where she is having a very poor ovarian reserve and where it is not possible to freeze anything, then probably we can do nothing about it. Of course, for a cancer patient, the type of cancer, the stage of cancer, the time at hand that we have for fertility preservation, and of course the financial and emotional burden. Similarly, for the non-cancer patient also, the stage of the disease, for instance, it is endometriosis. Again, the ovarian reserve in that patient, and definitely the financial burden, because she may have to go through many rounds, as you know, to collect the right number of eggs. We will talk about it as we go ahead. If you look at the fertility preservation indication in cancer patients in the prepubertal stage, you find that there are so many cancers in the females where we can help them. And of course, there are others in the reproductive age also where we can help them. Breast cancer leading the maximally, because many of our patients are essentially having cancer breast and they are coming for fertility preservation at young age. And then cervical cancer, ovarian cancer, endometrial cancer as well, rectosigmoidal. So all these patients can be helped by fertility preservation. Non-oncogenic conditions are also lots: hematological, autoimmune, as you all know, and gynecological diseases. As I mentioned, endometriosis, thalassemia, and sickle cell disease are pretty common. What about the genetic causes? We have so many: the Fragile X syndrome, Turner syndrome, where again help is available and eggs can be frozen early in the date before the patient becomes even menopausal or perimenopausal, or the ovarian reserve declines. So social egg freezing has come up in a very big way. Another one in this sex affirmation procedures is also gaining popularity very rapidly, and we find men and women changing sex, and therefore these are the patients also who can be helped to preserve their fertility. And of course, like I said, postponing menopause, this is one of the latest ones which has come into this arena. We shall talk about it. So if you look at the indications again, you find that majority of the patients who are coming to us are either of hematological malignancy or of breast cancer. These are the indications for cancer. But if you look at the disease otherwise, you look at endometriosis and you look at others, the majority of social egg freezing is because of the age, because they want to postpone their pregnancy. However, there are small amount of patients, say 2.1% of this graph, it shows that we are freezing eggs of endometriosis patients also, and there are others with poor ovarian reserve and ovarian surgery in the past who may also need freezing, fertility preservation. Coming to the males, medical conditions are, of course, you have the pre-pubertal cancers and other cancers as well. And again, you have chronic medical conditions, spinal cord injuries, pre-vasectomy. Some people might want to do a sperm cryopreservation. And of course, posthumous sperm retrieval is popular, especially in a country like us, although it is not legally yet, its legal position is not yet clear. And non-medical conditions, for instance, social reasons. Now, what are the fertility preservation options then in the males? Let's do this faster because it is easier, and then go on to the female ones. Sperm cryopreservation, like I said, has been going around for a very long time. It started with donor inseminations, and we all know that we can cryopreserve the ejaculated sperm. Surgical sperm extraction is also possible, and it is an outpatient surgical procedure, as you all know. Immature testicular tissue cryopreservation is the only option for prepubertal boys, and it is definitely practiced. So in the anvil is also the stem cell cryopreservation in adult stem cells in testes, and of course this is still to gain more popularity. It is still experimental. Now, coming to the current fertility preservation techniques in females, which is a major problem, not a problem, I would say a major chunk of the fertility preservation techniques today. We have two kinds of techniques. One is where you're trying to protect the ovaries, and the other one is where you are using the ART techniques. Where you're trying to protect the ovaries, you have the GnRH agonists, and you have the oophoropexy, that means ovarian transposition. So basically, you're just taking the ovary away for some time, either decreasing its function by giving the GnRH agonist, or you're taking it away from the area of radiation, and therefore you're protecting the ovary. So this is ovarian protection. And in the ART techniques, we have so many types. We have basically the oocyte retrieval, where you have oocyte cryopreservation, you have the embryo cryopreservation, and now we are also doing the IVM, and GV stage oocytes are frozen. They are again outside in vitro maturation takes place, and they form mature oocytes, as you all know. You're all embryologists here, and oocytes or embryos are then used later on. So ovarian tissue retrieval is also one of the popular ones now. This tissue is cryopreserved and then it is transplanted. We have more than 130 live births now. And again, in the IVM, again they are first taken out and then later on turned into mature oocytes and then used. There is another way where there is also something else that we are doing, and that is to reduce the estrogen, especially in breast cancer patients, where we are using special techniques like tamoxifen and letrozole to reduce the estradiol while we are stimulating these patients. So these are some of the current fertility preservation techniques, and if you look at the details of each one, we will understand that actually they are being used very, very rapidly and successfully in our day-to-day practice. And the cryopreservation of pre-implantation embryos, or the embryo cryopreservation, has been the longest in use. It has a 18.6% success rate. The survival rates of embryos are somewhere between 35 to 90%, varying upon the lab conditions and, of course, the clinics. The implantation rates also vary between 8 and 30%, but it is not acceptable in patients who are not married and they are not without a partner, because there you will not be able to form embryos. So these are some of the embryos. The embryo freezing cycle takes about 12 to 14 days, and there is a 10 to 25% chance of pregnancy per embryo stored. So basically, also this will depend upon the age of the patient, how many embryos you have, how many you have with you, and how many are actually going to remain viable after you done the thawing. Oocyte cryopreservation was considered to be experimental until 2012, when both ASRM and ESHRE actually declared and removed the label of experimental because they found that it was giving very good success rate. So then oocyte cryopreservation in 1 year jumped from 18.6% in 1 year to about 623 cycles, from 623 cycles in 14 to 7,518 cycles in 2015, which I'm sure is now crossed 10,000. So basically, oocyte cryopreservation is here to stay, and we all know that egg freezing also takes about 12 to 14 days because you're stimulating the patient. The live birth rate per ET is about 14 to 34%, depending upon the method of cryopreservation. This is SART data. And it can be frozen at any stage, any technique by slow or vitrification. We all know that we are using vitrification now most of the time. And cryopreservation of immature oocytes at germinal vesicle of ovarian hyperstimulation in such patients. Mature oocytes, of course, have a better pregnancy rate and there is less loss on cryopreservation. However, both these methods are being successfully used in clinical practice. So, like I said, we are using in vitro oocyte development as well. We are harvesting immature follicles, and more oocytes become available, therefore, for clinical treatment. No large doses of gonadotrophins are required, and IVIG in vitro growth of very small follicles is then done. These are the oocytes, and of course, this is what they look like when they are frozen and thawed. So, the last part is the transposition of the ovary. It is also a very simple procedure and it is effective, and GnRH analogs, these are also not expensive, and they are basically done when we are wanting to keep the ovary quiet. And of course, transposition makes the ovary move from the X-ray field. It can be laparoscopic and has been done for more than 30 years with a 16 to 90% success rate. The ovarian dose is reduced by transposition to about 5 to 10% only. And the technique, like I said, is either laparoscopy or laparotomy, where we can either put it behind the uterus or it could be hitched up on the lateral pelvic wall 3 centimeters from the upper border of the radiation field. So higher doses are more likely to be associated with vascular damage to the transposed ovary. But there are complications of this procedure, and most importantly, fallopian tube infarction. There may be a chronic ovarian pain because of the ovary being hitched up. The ovarian cysts can also form because of a problem with the blood supply, and not many, but sometimes there is a migration of the ovaries back into their original position. That means they fall back and they do not remain where they have been hitched. So the last part, of course, is that there may be ovarian metastasis. Pharmacological methods, like I said, we have the GnRH agonist, which is used to suppress the ovarian function. And it is not as popular as we think, but yes, it is being used also effectively in the cancer units, because when there is very little time and patient is wanting fertility preservation, we don't have time. This is one way that they are suppressing. Or even if the patient does not want children, sometimes to preserve the ovarian function alone, this is being used instead of doing any other method. Also, now we have apoptotic inhibitors which are being tried, and apoptosis, I shall talk about this a little later. This is important because we want to prevent the apoptosis of the ovarian follicles and the ovary, and therefore we are using certain agents so as to prevent it. Lastly, the ovarian tissue cryopreservation, which was supposed to be experimental some time ago, but now with more than 140 babies, it is here to stay, and it is becoming very, very popular across the world. Whereas in India, we don't have so many centers who are doing it for various reasons. And of course, the procedure, as you all know, is that you have to harvest the ovary which has been removed laparoscopically, and then the outer cortex is released. You make small pieces of the ovarian cortex, and then later on, and you freeze them, and later on they are again put back. So this is some of this is pictures of the surgical procedure which is being done, and we have to be very careful of this blood supply. It should be retained so that the entire ovary does not get deprived of the blood supply. So these are the pieces of the cortex which have been chipped, and they are used later on for, they are put back or transplanted later on into the ovarian fossa itself, or it may be implanted at other places where it had been done in the past, where the first one was done by Otke in the forearm of the woman. So this is how the ovary is later on staged after the cortex has been removed, and this is one of the original papers by Donez in 2006. So the first ovarian tissue auto-transplantation was done in 2001 by Utke, where he transplanted a section of the woman's ovary into her forearm and then gave her hormones to produce the eggs over there. Theoretically, then the eggs could be removed and used for IVF to achieve a pregnancy. They had good results with this. Initially, it was also done in the monkey. So now if we look at the decision tree, how do we decide what method to use and when to use? If we look at this, and this is a very recent proposal made by the team of Fertility in 2018. And if you have a consultation for fertility preservation around 40 years, and she has a favorable prognosis and future pregnancies are compatible with the patient's health, there is no high risk of infertility, or can infertility preservation be performed with low risk? If you have all these factors, then you have to think of the time frame that you have. First of all, you have to make sure of all this. If none of this is present, then you would rather not do fertility preservation. However, if you are going to proceed and your time frame is just less than 1 week, like I said, you have to give GnRH agonist. If you have a time frame of 2 weeks, you can do an ovarian stimulation. You can even do a dual stimulation to get more eggs if your time frame is 3 weeks. If you have a time frame of 1 week or a time frame of 2.5 weeks and there is a low risk of ovarian metastasis and malignant cells, you can do an ovarian tissue freezing, or you can do a freezing plus stimulation because you have more time, 2.5 weeks now. So you can do both these together. And of course, if the patient is going in for a pelvic radiotherapy for some cancer of hers, then ovarian transposition is to be done. So this is how, first of all, you decide what are the factors, whether you can actually do a preservation or not. For the major thing being the age of the patient, and if all this is fitting in, then you look at the time frame. And if you, depending upon the time frame, you decide what method you want to use. Now, what is the future then? This is the current thing. Currently, we are quite successful. We are doing our methods properly, but what is the future? We are bothered about cancer reseeding. We are very, very bothered. And somewhere now, we have started to get papers where we are looking at this cancer reseeding, and there has been a classification depending upon the type of cancer that the patient is having. And based on that, we decide whether we should be, what kind of a fertility preservation is required, and what should we be looking for in the future when we are thawing these embryos or the oocytes or the tissue. So what are the cancers that come into the low risk category for reseeding? Breast cancer, squamous cell cancer, these cancers are in the low risk. That means there is a less than 2% risk. A moderate risk is considered when it is between 2 to 11%, and this is these types of, even the breast cancer, which is infiltrating lobular subtype, this has a higher cancer reforming potential, and again the other cancers over here. Then what are the cancers that fall into the high risk of cancer reseeding, more than 11%? Leukemia, neuroblastoma, and Burkitt's lymphoma, to say a few. So therefore, with this kind of a thing in mind, what are we looking at in the future? What is it that we are bothered about? Sorry. So our fertility preservation techniques or the current techniques need to understand or improve in order to develop effective ovary protective substances, number one, so that they don't become apoptotic, like I said, and number two, there is no cancer reseeding. And again, improving the ovarian grafting by increasing post-implantation follicular survival. So basically, this part has to be taken care of. Even if we take out the grafts, are they going to have enough follicles to survive? And third, of course, is definitely to eliminate the risk of reseeding malignancies. So transplantation of an artificial ovary that contains matrix-embedded isolated follicles, or the application of a successful IVM system for primordial follicles. Interestingly, the IVM, the in vitro, the smaller oocytes or the preantral primordial follicles are actually not having any cancer cells. So therefore, it is a very good system. If we can actually develop our in vitro maturation systems better, we will be much more helped. And also the patients who have poor ovarian reserve will be helped and PCO patients, where if you can do this by improve your IVM, then you will be able to get a better cohort of follicles. So therefore, let us look at the change in the fertility preservation techniques that we are looking at. We saw what we are doing and what is going to happen next. Majorly, we are looking at the gonadoprotective agents. And if you see these, most of these agents are actually looking at the telomerase activity of the DNA and the cancer cells, but somehow to arrest that. But interestingly, we have here, if you can see, it is tamoxifen. This was of interest to me as well, because tamoxifen is also being used as a gonadoprotective agent, and it is said to reverse the radioactivity after the X-rays or the chemotherapy, or after the chemotherapy, the damage that has been done to the ovary. There are two papers, but both of these are on animals. And in both of them, they were successfully reversed. In the first one after radiotherapy and the second one after chemotherapy. So this is quite interesting and gratifying that we can use a simple thing like tamoxifen to improve the ovarian reserve of the woman. Second, agents to improve the tissue grafting. That means enhancing neovascularization. I said that we have to be very careful of the blood supply to the ovary, and we have to enhance this, and therefore we have to use these agents. Similarly, we have to reduce the apoptosis, so we have to implantation with the matrix, post treatment with melatonin. Again, another very interesting subject and another molecule which is going to help us to enhance this neovascularization and to decrease the apoptosis and of course these substances. Similarly here, what about the risk of reseeding cancer? Artificial ovary with isolated primordial follicles. Now it is not the grafts. You're taking out those follicles and embedding them in an artificial matrix, and then you are transplanting it. So it's basically one step ahead. You're taking out the follicles, embedding them in a matrix and keeping them like this and transplanting them later on. Similarly, you are culturing the primordial follicles to mature oocytes, cultured with cultured slices with primordial follicles, and these are again embedded in matrix, and hence once they are developed, they are finally made into embryos and transplanted back. So basically, in order to decrease the reseeding of cancer, we are taking 2 or 3 steps extra in the embryology so as to make it more safe for the patient. So here are the steps. If you can see these follicles, they have been taken out. These primordial follicles have been taken out. And with this fluorescent dye, you can see the seeding of cancer cells over there. So this is what we need to eliminate when we are looking at these cells within the ovary and trying to reseed them, trying to put them into different matrices. So this is what I was talking about, the novel use of follicular pool to postpone menopause. So you take out the ovarian tissue, cryopreserve it, and it is the ovarian cortical tissue, and then you isolate the follicles over there, and then you do an auto transplant when the woman becomes older. So therefore, she has postponed her menopause by another, say, 10, 15 years. So here is what you do. This is the graft, and you are isolating those cells from the graft to the cortical tissue. You isolate the follicles, and then you embed them in a matrix. In a matrix over here, you can see over here, this is the advantage of doing a virtual one. You don't have to worry about the text over here. You can see it very well. And enzymatic mix of Librase TM and collagenase has been done. So basically you mix that and you form a matrix wherein the follicles are then grown and then later on transplanted. There are disadvantages and advantages of this new method, especially for the older women, where there is a discussion saying that it is not going to have the same effect as the natural hormones that are being produced by the ovary. So time will tell us what is to be done for that part. Now, what about the pregnancy considerations? What about pregnancy considerations once cancer diagnosis has been made? Will she be able to conceive? Will she be able to carry to term? And will she be able to deliver a healthy newborn? This is when she is opting for fertility preservation and when she is not opting for. In either case, we have to consider a fertility later on. So with the cancer treatments themselves, there are different types of problems which can happen because of the different cancers. There may be a loss of ovarian function, which could be because of the chemotherapy that she has been given. And we all know that alkylating agents are most harmful for the ovarian function. Again, there may be a hypothalamic pituitary dysfunction because of the cranial irradiation, which may have to be given to the patient. Then there may be pregnancy-related problems like metabolic syndrome, cardiac dysfunction, preterm delivery and labor, low birth weight, and diminished lactation or failure of lactation because of irradiation. These are various therapies that have been used which can give rise to these problems. But we have to warn the patient about this and tell her that her fertility status may be compromised after these, and hence we are advising you fertility preservation. So if you look at the post-therapy fertility status, you have to balance between the age of the patient and the various protocols and radiotherapy that has been given to her in order to finally ascertain whether we are doing the right thing for her, one, and whether we will be able to achieve a pregnancy in this case or not. So when you have, after that, once the patient has had her complete treatment and she comes back to you, again have to assess her ovarian function as you would do for any other patient, and the same things hold true for her as the normal patients. But the good point or the happy news is that most of the studies are, even large data sets of 10,000 patients under 35 years are saying that there are actually no problems in patients who have had cancer therapy. So there is a pregnancy rate of about 3.7 to 7% in different studies, and these are patients who had not opted for fertility preservation. And it does say that there is a decreased risk of cancer in these patients. So basically, cancer patients on their own are also quite safe, and they do have a fertility rate even after cancer therapy. So it should not be ruled out completely. However, pregnancy complications they have tried to study that, and in adolescent and childhood cancer patients, there have been some reports of increased preeclampsia and gestational diabetes, but a subgroup analysis of this may be related to their having other fertility factors also, which may be giving rise to this kind of thing. However, the happy or good part of it is that there are no congenital malformations that have been seen. And although the risk may be seen due to the effect of cytotoxic drugs and radiotherapy, but definitely in the study so far, we have not found any such things. This is a retrospective cohort of 590 breast cancer patients now who were aged less than 40, diagnosed between 2000 to 2016. This is a very recent paper of 2019. And again, in this small cohort, it was found that there were no pregnancy concerns in these patients. And this is a very important thing that clinicians must know. And the pregnancy rate, sorry, I have not written it, in the pregnancy rate in these patients was about 18%. So therefore, it is quite gratifying to see that whatever women came back after fertility preservation have had a good pregnancy rate, and we should not be so worried. So yet, despite all this, we find that only about 36% are referred for fertility preservation by GPs. They are not informed, maybe because there is lack of time, lack of knowledge, and also because of the perceived poor success rate that these people feel that we have. And also the patient is quite concerned and quite anxious, and there are different reasons which have been seen. So if you see this Italian study of 2018, it says that, although they had this breast cancer only and they were eligible for cryopreservation, only about 40% of these women, 55% of these women accepted it and the others did not. So similarly, it is important to understand the psyche of the patient and the psyche of the doctor who is referring the patient, and the psyche of the oncologist also who is treating the patient when we are looking at a patient for fertility preservation, because it is basically all these choices, all these things which are important in order to judge whether this patient is going in for a fertility preservation or not. However, we as fertility specialists and embryologists, we all know that this is a field which is emerging and it has got a good success rate. So we should not, although we should not try to push the patient for getting into this kind of a state. I mean, in the sense that we do advise it, but we should not force her to go through it. But we should always inform them that it is not a bad decision to undertake, and there is a good pregnancy rate following fertility preservation once they become well. So with that, I would like to finish my talk by saying there is only one way to discover the limits of the possible, and that is to go beyond them into the impossible. And that is why we need always to currently to review our current practices, and this is actually a means to secure a safe future. So therefore, ladies and gentlemen, we are actually on the right road ahead. And basically, from the Southern team, I would like to thank you all very much for having me here. Thank you very much for this opportunity, and thank you for this wonderful meeting. Thank you and congratulations.